Well, when we talk about antenatal care, we actually talk about pregnancy before it's even formed. We need to take care of the mothers, not just antenatal itself. We actually need to take care of the mothers pre-pregnancy. And why is this so important nowadays is because a lot of women in Singapore are having babies much later than the last time. So that we are now qualifying ladies who deliver after 35 years of age as elderly mothers, whether it's the first baby or second or third. As long as they have the babies after 35, they're considered as elderly. So with this problem in mind, we actually need to discuss with couples, even before they have the baby, about how to take care of themselves before the pregnancy even starts. So we talk about antenatal, but actually we talk about pre-pregnancy care way before antenatal care. So what do we do during the pre-pregnancy period is that we actually run through a series of history with them and making sure there are no family history, any medical problems, as well as themselves, any medical problems. We're actually looking for specific medical problems like genetic diseases. In Singapore, it's very common to find this genetic disease called thalassemia. It's actually existing in about 3 to 4% of our population. So this is quite a big number actually, and we can just do a simple screening test, a simple blood test. We can actually find out whether they have or not. The reason why we need to know is that if they carry on this this thalassemia, there is a risk when the baby gets a severe form of thalassemia, and the kid might need the blood transfusion for the rest of their lives. So it does actually affect their future. Then we also check for infections, VDRL and all that, because these are important for hospital admission to prevent contamination in other patients as well as things like hepatitis. We also check for rubella, because rubella is a disease, it's a problem which if the mother has or is not protected against, there's a risk in which they can get infection to the baby with rubella, and that can cause severe defects in the baby as well. So other than the pregnancy care, pre-pregnancy care, we also need to enlighten them into what sort of nutrition they need to take care of, what sort of food they need to take, any extra exercises they might want to do, and so forth, to prepare themselves for the pregnancy. Once the pregnancy is actually confirmed, that's talking really about antenatal care, we will advise them to quickly come and see us as soon as they can, so that we can do some little tests for them, in the sense that we need to do ultrasound scan just to make sure the baby is in the right place, in the correct position, not in ectopic, what we call ectopic pregnancy, which is actually a life-threatening problem. We also like to find out whether they have how many babies. Sometimes they're triplets, twins, because most of the time they'll be singletons. But the reason why we're so interested in this issue is now there is a lot of pregnancies are conceived artificially. So the risk of having multiple pregnancies itself increases. But with multiple pregnancies, there is also increased risk for medical problems, as well as problems for the babies, the higher risk for chromosome problems, and the mothers run a higher risk of having things like diabetes, high blood pressure, and so forth. So the first time they come to see us is very important. We also need to see the babies, are they well, are they growing well, and so forth. In the first trimester, when the mothers come to see us, we also counsel them for other issues like the risk for Down syndrome. So whether you are a young lady, 21, or whether you're 40 years old or 45 years old, first thing we talk about in terms of common genetic disorders is things like Down syndrome. Now, Down syndrome, unfortunately, the risk of getting it is related to the mother's age. So as soon as you cross 35 at delivery date, your risk naturally increases a lot. So for younger mothers, the risk is not so high, but they still run the risk, even if you're 21. So there are screening tests now available using blood tests, using the mother's blood without having to do any invasive tests. The tests include commonly the Oscar test, which is actually just taking the mother's blood, and we can actually assess the baby's hormones and enzymes and so forth, and we can calculate the baby's risk of getting Down syndrome. There's a new test available called non-invasive prenatal testing that's actually using the mother's blood again without any invasive tests, without poking the mother basically, and we can actually pick up placenta cells from the mother's blood. And with that, we can actually assess the baby's DNA, because placenta and the pregnancy and the baby basically will have the same DNA, and we can actually check a few chromosome abnormalities like Down syndrome, Edwards, Patals. We can even know the gender of the baby, but of course that's usually not the main aim. And we can also find some of the unusual, what we call DNA problems, we call microdeletions, and which may affect the baby in terms of their long-term health and mental effects. So now it's available, and you just need to do sample the mother's blood and it's sent to the United States, usually where the labs are, and you get a result about 7 days to 10 days later. So we can do that in the first trimester. Now, however, all these tests are just screening tests. So if the result comes out to be positive for any of the problems, we still need to do an invasive test, for example, chorionic villus sampling, in which you take a sample of the placenta, or amniocentesis, which is usually done around 15 weeks, and we can then confirm the baby's actual detailed chromosomes, and then we can find out baby is really affected by all the problems that we picked up from the non-invasive tests. So that's what we can do around the first trimester. When it comes to second trimester, the mothers have to cross another burden and another hurdle. That means other than all these screening tests for chromosome problems, the next step is actually crossing the structural abnormality scans. So why do we need to do that is, you see, first thing is when the pregnancy is formed, the genetic part will decide genetically how the baby is formed. But the structural part, that has nothing to do with age. So whether you're 21 to 50, if you get pregnant, we still need to look at the structural defects. So structural defects are quite separate from genetic problems. So we actually look at the baby in detail from head to toe, every part of the structures, but unfortunately, it's not perfect. So we can pick up about 80 to 90% of the structural problems, but you really cannot pick up 100%. Of course, there are specialists who do all these detailed scans. We can pick up to 90%, but there's still structural abnormalities which we cannot see because a lot of organs are still, in development. So by the time they are due for delivery, you might see certain defects which are not obvious when it was first scanned at 5 months or 20 weeks. Yeah. But during the third trimester, of course, the mothers have to be monitored in terms of their blood pressure, their weight, and so forth, so that they do not be excessively overweight, because that will put them at higher risk for diabetes and hypertension. And of course, there's a very severe form of problem called preeclampsia, and that actually can affect both mother and baby together. So this problem is associated with high blood pressure, the mother getting a lot of water retention, and actually causes baby to slow down in growth. And sometimes they actually cause bleeding problems in the mother as well. So this disease is common in the old days, but it's much lower compared to the old days now because of better nutrition and better health, and better people are take care of themselves much better than before. There's no such overeating as before. So people are really watching it now. So it helps a lot, but it still exists. And the reason is because it's actually a body reaction to actually react to the baby. So it's a reaction which you normally cannot stop. It's almost like an immune system change, and it's almost like a rejection of the baby. But it depicts itself as like high blood pressure, and then they get all sorts of other issues. So usually we watch for all mothers for this, and they unfortunately only appear around the third trimester. So in the initial stage, everybody looks fine, and suddenly you get this issue, and then you might find you might have to quickly deliver the baby and so forth. That's one of the reasons why we have to prematurely deliver some of the babies. In normal circumstances, most pregnancies will deliver normally, maybe 90% will deliver normally. But there's always a 10% chance something may not be correct. For example, the mother may have medical problems, high blood pressure, sometimes diabetes, sometimes the baby, for example, may be too big, or even other issues like sometimes there's not enough water, or the placenta is very low. Then in these cases, we have to discuss with the parents that the mode of delivery probably for the best interest of the baby as well as the mother, is by cesarean section. But in general, most babies will be able to deliver normally. Nowadays, couples are asking for cesarean sections electively. That means they choose for whatever reasons they may want to, for sometimes social reasons, sometimes they just say it's the best time for the baby to come out. Nowadays, we do not stop them from choosing it because now parents have a right to decide how they want to deliver. We don't say it's dangerous anymore simply because there's improved technology in medical healthcare. Whether it's, last time we talked about complications of cesarean section because they bleed a lot, they may have injuries and so forth. Of course, if we do it properly, the risk of injuries is not there. Furthermore, blood transfusion is now easily available in cases which need transfusion. It's now easily available. So with technology and improved healthcare, cesarean sections are no longer as dangerous as it was before. There are, of course, disadvantages because sometimes if a cesarean section, you may have a bigger scar on the tummy, then they worry about unable to breastfeed and so forth. But because of painkillers available, cesarean sections are reasonably well managed nowadays. But there are certain circumstances in which we actually induce a labor. I'm sure people have heard about that before. Well, for medical reasons, it's sometimes worth inducing because there is still a risk when you induce a labor. There's a small chance in which it may fail. So you end up with a cesarean section. So again, the parents must be counseled properly before we do induction because the failure rate for induction is around 10% too. So we're actually putting the patient at a higher chance of getting cesarean section. For the patient who do go into labor naturally, then we also discuss with the patients and the husband the management of the pain because labor itself is definitely very painful. So there are three main types of pain reduction methods. One is using gas. The other one is using an intramuscular injection. We give a drug called pethidine, which is a sister drug of morphine. So it really gives them kind of high effect plus a reduction of the pain. But the best reduction of pain is by epidural, and that's usually given by the anesthetist. We usually have a group anesthetist who will help us to manage all our patients in labor so they can get the epidural all 24 hours a day. So that would seem to be the best management of pain for patients in labor. Well, after the baby is born, the baby will usually be passed on to the midwife who will then actually assess the baby's well-being. We will check the baby's color, baby's breathing well or not, as well as we also clear the throat for water because usually the baby, once it comes out, there's a lot of fluid in the lungs, so we need the baby to cry and get the water out. So actually gone are the days when we need to whack the baby's backside because we just have to suck it out, stimulate the baby, and the baby will cough out the fluid. So we don't have to whack them as you see in movies and things like that. And then of course we also give a small injection called vitamin K, which is given to all babies after birth. This is to prevent bleeding problems in the baby. We usually keep the mothers and the baby in the hospital maybe 48, sometimes up to 72 hours because that's when they get actually jaundice. So jaundice is managed by the pediatrician because we assign a pediatrician to all the babies that are delivered in the private sector. And of course, they always be followed up with vaccinations. Common vaccination we give is the hepatitis B, which is usually given before they actually leave the hospital. And then they'll be followed by a series of vaccinations over the next month or two. So they usually have a program for them. We also do a hearing test for the baby. And we also do some other blood tests for checking the jaundice, thyroid function, and so forth, because these will affect the babies long term. Yeah, if they have thyroid problems, sometimes you find they need to be treated quickly because if the thyroid is not functioning well, they actually get brain damage as well. And in diabetic babies, I should say the mothers who are diabetic, the baby's sugar has to be monitored very closely because they can actually get very low sugars instead of high sugars because they get a reverse reaction in the mother who has high sugar in their blood. So there's a lot of things we actually need to check out the baby as well. And after that, the babies can be followed up either by the pediatrician or they can be followed up by the polyclinic doctors.